My name is Amanda Garzon. I'm the Chief Operating Officer of the Hydrocephalus Association. I have been with the Hydrocephalus Association since 2012. And in my capacity as COO, I oversee all of our patient programs as well as our advocacy and communications and marketing work. I also have a 21-year-old daughter who is living with hydrocephalus. She has 2 shunts, has had 17 brain surgeries, has a seizure condition, and is an incredibly bright, very successful sophomore in college. So she is incredible. And her younger sibling, Sophia, who often speaks on sibling panels. So some of you have met her because I recognize faces when she has spoke on what it's like to be a sibling of somebody who has hydrocephalus. So that is just a little bit about me. Many of you know the Hydrocephalus Association. You're here because you probably came through us or you came through the foundation, who is also co-hosting with us tonight. So let me take a second and introduce, let me lay the ground rules quickly. If everybody can stay on mute when you're not speaking, that would be wonderful. If you are on a computer, at the bottom, when you hover, maybe your menu's at the top, you will see the ability to send us reactions to things. You can clap. You can also raise your hand. And so I will be taking questions. And so when I see your hand go up, you can do it this way if you're not comfortable using the emojis or reactions, but you can raise your hand and we will get to questions in the order that I see them. So definitely, hold tight. When we asked Dr. Frim and Judie to come speak tonight, I want to just remind everyone that they are coming to share their experience of working with our community as medical practitioners, but they are not here to provide medical advice for your specific child. So please remember that when you ask your questions. So if you can phrase your questions in a way that is general and consumable for everybody on the call, that would be wonderful, because we are not going to be providing specific medical advice on this call for your individual case. As all of us know as parents of children with hydrocephalus, every single one of our kids is different. They present differently. They go into shunt failure differently or ETV closure differently. They have different challenges and they have incredible successes, and they are all unique. So let's just all keep that in mind. And I also would like to say, please celebrate each other. Some of us might ask questions tonight that put us in a position where we're feeling very vulnerable to ask them, because sometimes these questions are hard for us. We're bringing up things that are very emotional for us. So let's all commit to celebrating each other as we support each other on this call, and we really can learn from each other and from Dr. Frim and from Judie. So if everybody's good with those ground rules, try your reaction emoji and give me like a clap or a smiley face. Oh, Adriana's got it. I got a thumbs up. Oh, Jen. Okay. Oh, they're all coming now. They're starting to happen. And I do hope that you do take your cameras off. It's okay to be eating, drinking wine, sitting with your kids on your lap. All of that's completely legit. We do want this to feel like we're together in a room. How long has it been since that's happened, right? And the last thing I'll say before we get started is I do want to remind everyone that in July, we will be holding our annual conference talking about being together. It is an incredible way to actually connect with other individuals on the journey, whether you're an adult living with hydrocephalus yourself, or you are a parent of a child living with hydrocephalus. We have a teens track. We have a track for siblings. So please take a look, hydrocephalusconference.org. You can find out more information. It's in Austin, Texas, July 14th through 16th. And with that, I am so happy to introduce our guests for tonight. Dr. David Frim, who's an MD and PhD, and he's the program director at the Margaret Hackett Family Program. Dr. Frim is an internationally recognized neurosurgeon and neurosciences researcher who has specialized in the care of children and adults with congenital central nervous system anomalies for over 20 years. Dr. Frim's research and his innovative approaches to treating hydrocephalus, Chiari malformation, syringomyelia, and tethered cord syndrome have attracted patients and families from national and international sources. Although Dr. Frim is no longer practicing clinically, the surgical team at the University of Chicago Medicine is continuing his legacy in treating pediatric patients with all forms of neurosurgical pathology. Dr. Frim continues to be an active medical researcher and educator for the Margaret Hackett Family Program and also serves as principal investigator on laboratory and research studies related to brain injury, intracranial pressure dynamics, and cognitive outcome after treatment of hydrocephalus and Chiari syndrome. He's joined this evening by Judie Holleman. Judie supports both research and clinical care for the Margaret Hackett Family Program. During her research activities, Judie helps develop clinical research protocols and clinical trials. If people can mute, that would be great. While working with patients, she operates as an experienced clinician that helps interpret and navigate the pathway of care. She brings a wealth of experience and a strong commitment to caring for patients impacted by CNS anomalies. So thank you both for joining us this evening. It was a mouthful, like reading the introductions. You guys are incredibly accomplished. We could not be more fortunate. Talk about a true Ask the Experts. So thank you both for being with us.
You're very welcome.
I would love, just because we are working closely with Julie and Rosa. I'd love it if you would open us up by just telling particularly the local Chicago people a little bit about the Margaret Hackett Family Program in case people want to reach out and find you. And then we'll get into some of the hydrocephalus stuff.
Where's Judy? I guess she's got to make me do it, right?
I'm here.
She's unmuted.
Yeah, I wasn't sure if you wanted to talk about Margaret Hackett or if Julie wants to talk about Margaret Hackett and what we're doing with the family program.
Want me to do it? I can do it if you want.
Okay.
Okay. That's sort of like once upon a time, all of a sudden there was a foundation. That's the story. Margaret Hackett is a wonderful person, and she has a lot of problems, not least of which is hydrocephalus. And she has a wonderful family, and she's grown up with a very interesting disease called craniometaphyseal dysplasia, of which there's just a few hundred people in the world that have that. She of course, because I always ask her this every couple of weeks or whatever, doesn't mind if we talk about her disease, which she has more or less overcome by now. But her family has some significant meaning. And now that Margaret was grown up, they came to us and wanted to sort of give back to all the other things that we had been doing. Not so much just for Margaret, but for everybody. So the Hackett family then started this foundation that's dedicated to the treatment of patients, both children and adults, who have congenital anomalies of their nervous systems. And it's quite a long list if you kind of line it up. There's a lot of people who have hydrocephalus that now go to see the Margaret Hackett part of the institution, and so many other diseases, some of which are relatively easy to treat, but many of which are difficult, and some that we don't really know how to treat. And so that entity is divided up into three parts. One is an advocacy part, and that's what Judy's probably going to talk about in a minute or two. And that's to help the patients and help the patients' families and advocate for them both inside and outside the hospital and try and make sure that things run smoothly. There's a second part that's a consortium of now 5 places around the country. We've all decided to get together and try and get a lot of data from a lot of different patients who come from different parts of the country. And we're going to be using those patients if their parents are wanting, or if the older ones would want to join one of these sort of consortia trials, then we'll be watching those patients and trying to figure out what the best treatment might be for their diseases. And there's a third part of it that's sort of, what are we going to do next kind of thing. And that's very important, because eventually we're going to have to cure all the diseases that we can. Right now, that's kind of hard, but as time goes by, I think that we're getting a little bit better at it. Certainly, I think that we're trying very hard. So I'll hand off to Judie, because probably she should talk about the advocacy part, because that's a very exciting part of the Margaret Hackett entity.
Yeah, so thanks for having us. I really appreciate it. So I'm Judie Holleman. I'm one of the pediatric nurse practitioners. I think you can hear my family in the background, so I apologize for that. They're cleaning up from dinner, trying to be helpful. I am one of the pediatric nurse practitioners at the University of Chicago, and I've been taking care of kids with hydrocephalus and some young adults for probably about 20 years. I'm not sure I recognize anybody on the call, but if I've taken care of your child, I hope it was a good experience. I do not have a child with hydrocephalus, so some of the concerns of parents, although I've heard what parents express, I have not necessarily experienced that personally. I do have a child with a different chronic disease, so I do understand some of the angst of when things come up that, what if, do we need to go? Are we going to be in the hospital? Does this mean, what does this mean? Are we going to miss school? Are we going to, my child would not necessarily have to have surgery, but I do appreciate the angst from a parent perspective of what if it's the shunt and what if we need surgery and those kinds of things. So I hope that we can talk about that tonight. One of the things that we've recently did in terms of advocacy is I gave a presentation to the school nurses at the within the Chicago public school system. That was a very large and very exciting event. But I felt like I was sharing my experience of what parents have shared with me. But I thought maybe one of the topics we could talk about tonight is kids with hydrocephalus in school, and what are the concerns that parents have, or is there something in particular that you would have liked if I had said? Hopefully I said it. Yeah, if we could, touch on that subject. I'm sure there's plenty of other subjects we can talk about, but that was one thought of mine, is when I gave this presentation, I thought, boy, I really hope I'm representing the parents well and expressing what they would like from their school system or from their teacher or from the nurse that's in this school. My kids go to a smaller school and there isn't always a nurse present, and I'm not standing in the shoe of a mother or a father, a caregiver for a child with hydrocephalus. So yeah, if we could talk I would like that as one of our subjects tonight, but I'm open to any subject that you guys want to talk about. I did not necessarily prepare a whole talk because I feel like there's so many pieces to hydrocephalus, and I think I want to learn from you as much as maybe what I can share with you and what I know and what Dr. Frim knows about hydrocephalus. I do want to call out that on the call is Lainey from Child Life, and her and I work closely together. She is a child life specialist. And so again, her specialty is a little bit different than mine, but we are trying to partner up and really advocate for parents, either within the school system, the healthcare system, needs that kids might have with kids that have hydrocephalus that come into the hospital, or is there a special way we can meet their needs in a way that's a little bit different from other kids that are coming in? So yeah.
Well, I think that we're going to have a fun conversation tonight, because I think that all of us parents here would be happy to provide you insight, not only on the school situation, but also in the hospital, what would help us. So thanks, Judie. And I just want to say the Hydrocephalus Association is really proud to be and so happy to be working with the Margaret Hackett Family Program. And for those of you in Chicago, I hope you definitely take advantage of the wonderful services that they are offering, and we will continue to work closely together. So it's always great to forge new partnerships. But let's talk hydrocephalus, because we do have some questions that came in beforehand, and I have a feeling people have some questions here. And if you raise your hand, because we have so many people on the call, you're on 2 screens for me, that will help me. It'll jump you to the front of my screen. So that's how I'll know you have a question, and I'll see you if you're not on my first screen. So one of the questions, and I'm just looking to the right because that's where my second monitor is. So one of the questions that somebody talked about was what goes into the decision about when to treat, particularly an infant with hydrocephalus? Do you shunt right away, or do you ETV right away? Is there a waiting period? So Dr. Frim, I know when my daughter was young, it was pretty much like you saw the ventricles get big, a shunt went in. We weren't even doing ETVs 21 years ago. So not widespread anyway.
Nobody knew what it was.
How has that changed in the past 21 years?
The most interesting part of this, to begin the conversation, is maybe 25, 28 years ago, a lot of patients were dying from hydrocephalus. And some of them were infants, and some of them had other problems. Some of the babies were delivered, and we didn't really know how to take care of them. That was when I was in elementary school. But there's a lot of things that have grown out of all the work that's been done. The first shunts, they were just so totally life-saving, it was like a miracle. And the best part was that if it broke, you could just fix it. And that's pretty awesome if you think about it, because rarely is there a disease that is potentially lethal, but one that you can fix. And if the way you fixed it stopped working 5 or 10 years later, you could fix it again. So that was a big breakthrough, though it's still not right, because the goal is that everybody would grow up and everybody would be just like everybody else. That happens to many of the children, but not all.
Oh, Dr. Frim, you went on mute. Sorry.
Sorry. So I think the answer to the question boils down to 2 things. One is, what do we do, the medical caretakers? And that's where things that keep the hydrocephalus at bay, if you want to think about that, by making sure that the intracranial pressure, so that would be the pressure of the fluid in the brain, is not too large. And the brain, if it can be kept normal, or as normal as possible, then there's really no reason that someone can't live a relatively normal life. A lot of it may depend on what happened in the first few weeks or months of life. That's a very vulnerable period. And some of it is what happened over the next coming years, because though the shunt is a miracle, the shunt is also sort of a pain in the neck, if you want to think of it. and it can be deadly if it becomes infected with some very virulent bacteria. That can be a big problem. So we can take care of that. We're very good with the shunts. We're very good with making little holes in the substance of the brain so that the fluid can get out of the head and be restored elsewhere by itself. And so the first answer to your question is we always have a plan. And the plan always has to do with making sure that the pressure is not too high or too low, that the patient doesn't have something that's going to be very bad, like an infection, and is going to be able to be taken care of and get back to the way they should be, with the shunt carrying its fluid and the fluid being clear, and then everybody's very happy. The other half is sort of the caretakers, mom and dad, grandparents, older siblings. We sort of think that taking care of somebody with hydrocephalus and a shunt it's sort of it's a whole team effort. And we encourage that. Because even somebody who looks great with a shunt and everything still needs to be watched when they're young, and still needs to be careful in a variety of reasons. And so I think that the families that are able to be that way without making too much of a sort of, you can't do this, you can't do that, but being reasonable, I think that's also very important, because part of it is growing up and not getting infected and not having anything bad happen to your brain. But the other part of it is you want to live your life, and you want to live it the way everybody else does. And you want to grow up, and you want to meet people, and that's also very important. So I'll leave that there. Judie probably has a few smarter things to say right now.
I don't know about smarter, but so one of the things that I bring to neurosurgery is, I'm not a neurosurgeon, but I am a nurse practitioner. And so when Dr. Frim and his colleagues might come to me and say, what do you think? This baby has, a large head or hydrocephalus or enlarged ventricles, or what do you think we should do here? Should we go to shunt? Should we go to ETV? And not that I'm telling him a surgical plan, which I'm not. He's the surgeon. It's not my job to tell him what to do, but it is my job to tell him, yes, this baby has hydrocephalus and is at risk for maybe other things. Is there some genetic component? Is there some nutritional component? Is the hydrocephalus part of a syndrome? Is there some reason that we think this baby might be challenged in recovering from either the shunt or the ETV? I like to think of ETVs as being a little bit easier to recover from. And I don't know why that is, maybe because there's just one incision as opposed to putting in a whole shunt. There's, then you have to worry about the belly and worry about the skin. And is this a preterm baby? Is this a full-term baby? Is this a full-term baby that's experienced a really dramatic delivery or pregnancy? And he relies on me to add those extra pieces to help him decide, is it VP shunt or ETV? Or if we could do an ETV, do we think we're going to end up at shunt? Do we need the baby just to grow for a little while? So those are the extra pieces that I might add into the story. But really, ultimately, the way that we kind of make the decision is we really do go talk to the parents and say, here's the options. Some of it is based on, if we get an MRI and it looks like the brain is gonna, relax nicely from doing an ETV, that might be one piece of it. But the other piece is, how quickly is this baby going to recover? What are the other, components related to just going to the operating room. Is this a baby who has maybe an airway we're worried about? Are they going to stay intubated for a while? Those kinds of things would be the added pieces that we definitely talk about to make those decisions. It's funny that you asked that question, because just yesterday we were having this exact same conversation with a 1-day-old, trying to figure out, not figure out, but what was the best option for this particular really, really, really otherwise healthy baby, except this baby has hydrocephalus, and what's the next best move? So I'm glad you asked that question, because I was just thinking about it yesterday, like in depth.
Yeah. Well, I think it's interesting because I know that there's also a trend in some surgeons to wait a little bit and see what can happen. And before they necessarily jump to a shunt or an ETV. And the question came in because the woman who asked it, her child, I think it's a daughter, they have chosen not to treat because the hydrocephalus isn't progressing. And so they're kind of waiting it out a bit to see what happens. And so I think, that can be scary for a family to go home untreated, just as scary as it is to go home treated, right? Because I think you're in the same situation in both instances where you really have to know your child, and you really have to know the signs that something could be going wrong, that the pressure is increasing inside your child's head. So, it's almost like a win, lose, lose, win. It's like, do you do treatment or no treatment? They're both kind of scary. One of the things you said, Judy, that I loved, and I'd love some parents to chime in here. One of the things that I found the most intimidating yet the most refreshing with my daughter's care was the first time the neurosurgeon turned to me and said, well, what do you think? I'm like, well, dude, what do you mean? What do I think? Like, you're the neurosurgeon. But then I really, as we started talking through everything, what he was doing was really acknowledging how much I know my child. And as we were trying to decide, should we wait a little bit, the scans were a little inconclusive, could have kind of gone either way. But it was it was scary to me at one level, but at the same time, then it was really incredible, like so nice to be asked and to be a part of the decision, whether maybe he had already made the decision in his head and he wasn't really asking for my opinion, but at least he made me feel like he was. And now as my daughter's grown up, and, I am very close to her doctors, and it is much more of a teamwork. And it seems, Judy, what you were saying, that there seems to be that kind of feeling in your practice, that it feels very team oriented. So I'm curious, especially with so many parents on the call, what do you want parents to bring to the table to help? And how should parents be prepared? And what do you really do when you're talking about this teamwork?
So one of the things we do is I make sure all the new parents actually get that hydrocephalus booklet. We call it the Hydro book. I turn to the pages that have a picture of a shunt, so that parents, especially newborn parents, especially if it's their first child, they're still adjusting to, now I'm a parent, and now my parent has a child, now my child has an issue, and now I have to learn about the issue while I'm recovering from having a baby. That's a lot. And so I do give them Hydro book, and I do tell them, read it at your, when you have opportunity, but this page right here is the page that I want you to look at, and we'll talk through it. The different pieces of a shunt, and what does that mean? And how do we, if they want to know, how do we put it in? How does it get tunneled down to the belly? What does it mean that the catheter's in the belly? And then I usually ask them, does that make sense? Do you understand? Do you have other questions? There's always more questions, that's what I want. We don't come from, our practice is that we like parents to be actively involved and engaged in asking questions to a full understanding as best they can for the situation. There are times we feel like we have to move a little bit more quickly. Either the baby, maybe there's a lot of pressure on that baby's head and we really need to do something more quickly. There are other times that we can wait a little bit. And I agree with you that I think sending somebody home with this new diagnosis, and then if you go look it up on the internet and Dr. Google, hydrocephalus is a very scary thing to Google if you're new to the diagnosis. And so I still take the book out and we still go through it and we still talk about what are the things that should bring you back to the ER? What are the things that should warrant a phone call? And we always tell our new parents, if ever you're unsure and you think the baby's not quite right, just come back. Just come to the ED. We're here. We're here to help you. We understand it's overwhelming. We understand it's a new diagnosis. We understand maybe this is a newborn that you're just getting used to this new baby. But that's why we're here. We're here to help you. I think it's helpful. I think it's a good approach. Seems to have worked for quite a few years. And I hope most parents are satisfied with that answer. But I do think it's a lot to take in. It's a lot to understand.
It is. And there's so many emotions when your child is first diagnosed, because it's not just you're trying to process all this information and take it in and learn about everything, but you're also trying to process your own emotions. And, you know, parents really you should not underestimate everything that you're also going through and making sure that you have support you need while you're trying to process all of this. For some of us, it's a different future than we ever thought. Well, for all of us, it's a different future. We have a child who has a chronic medical condition now. There is no cure. There are some kids who kind of, you know, their hydrocephalus stabilizes and they grow into adulthood and have very minimal to no, you know, interventions. But for many of us, that's not going to be the case. And for our children, so it has changed our lives. For some of us, we'll have children who will be dependent on us for our lives too. So there's a lot of emotions that we're processing as well. I want to let Heather jump in and ask her question. Heather, I see your hand raised.
Yeah. So we really like our neurosurgeon and everything, but we don't have that same kind of relationship where like he like brings us into the conversation. Usually it's me, and I almost kind of feel like I'm bothering him because I am that person who asks a lot of questions. I'm also that kind of person who 100% looked up the surgeries before she went through them because I wanted to know what was going to happen. But I'm just wondering, how do you get that kind of relationship with your provider and also really with the nurse team that's taking care of them in the hospital? Because every time my daughter has been hospitalized, which has been 3 times, there's only one time I felt like the nurses were actually in my corner. Every other time we had issues with them, you know, not taking care of her properly, not checking things properly. And it just felt like we couldn't get them in our corner. Like they didn't, I don't know, want to back us up or understand what we were going through or anything like that.
Heather, that's a phenomenal question. Thank you for asking that, Judie and Dr. Frim.
Oh, that's a difficult question.
Mm-hmm.
First, I would say that situation at our hospital would be very rare. It's pretty rare in the adult area, but it's very, very rare in the pediatric area. It just seems to be that over the years, we've sort of gotten almost all of the U of C peds nurses to be great nurses, but also somebody who, in a sense, is a little bit of a friend, both to the child and then to the family. What's happening to you, Heather? What's happening to you, I think, is you may be in a hospital that I'm sure that nurses are very well trained and they know how to do all sorts of things, but it may just be that that particular facility is not quite as what should I say, family friendly or patient friendly. What I would recommend is that you need to talk to the nurses, or if they don't want to talk to you, is probably a head nurse, whatever, and be very, honest and be very cordial, but say what's on your mind, because you want to know what's going on with your child, right? It's your child. Have you gone to medical school? No, but you still need to know what's going on with your child. and the worst thing that I've ever heard of from one of our patients is that the first place they went to, they had no idea what was going on. And that just was a recipe for disaster in a way, because there's already so much fear and anxiety that just if you talk to Judie Holleman for 45 seconds, then you know that she will take care of your child. She will walk up to your child, she will pick up your child, and your child will just cuddle up to Judie Holleman, because she just has that magic. Not everybody has it, but the idea is that the baby, for some reason, probably knows that Judie wants to take care of her. I'm sure that Heather wants to take care of her child just as much, and know how to do it, though. And that's very important. And if there's a problem, then you have to be aggressive about going to the head nurse, or going to whatever, or talking to one of the physicians. It's a very important thing, because it's scary, and there has to be some problem that is going to come out of it, unless the behavior is changed.
Yeah, I would second some of those statements. I feel really bad for anybody that's had experiences along that same line. I see some people shaking their heads that maybe this is more common in other facilities. I agree. I would, respectfully go to the nurses and say, I want to get on the same page with you. I want to understand. Here's my top 3 concerns. Can you share with me your top 3 priorities in caring for my child? How can we get on the same page? And then the surgeon, it's the same thing, a very direct conversation. This is my child. Here are my top 3 biggest concerns, fears that I'm worried about. I want to get on the same page with you. What are your top 3? If that doesn't work, I would surely hope that any administrator would be willing to hear that there's a disjointed connection between parent and provider. In this day and age, in 2021, we should be able to use words like we're disjointed, we're not quite connected, we're not quite on the same page, in a respectful way, because I agree with Dr. Frim, it is your child. This person is your child that you're going to take home, and to having confidence in the competence of the people caring for your child really can go a long, long way. If anybody on this subject has a suggestion beyond what this public conversation is, and you have a private suggestion that you want to bring to Margaret Hackett, these are exactly the kinds of things that Lainey and I are looking for to advocate for parents at facilities outside of our own. So if you have a great, hot tip that you don't want to share publicly, just send it to me. I'm happy to hear it from that perspective, but I'm open to other parent suggestions on this topic.
Yeah, Judy, to just kind of echo what you said, like Judy said earlier, my name is Lainey. I'm one of our child life specialists at Comer Children's Hospital in Chicago. My main role is to make sure your child is still staying a child in the hospital and providing emotional support to you and your family and other children. Definitely what Judy said, any other suggestions on how we can improve patient care, because ultimately this hydrocephalus is a lifelong condition, and there's going to be more hospital, visits and appointments and scans and things like that. And how do we make sure that your child is set up for success in the future, and you and your family are set up for success? A suggestion that I know that other families have done with different conditions is, prior to that admission, and something that Judy and I were talking about you know, a couple months back, is kind of having a list or a poster and all about me, about your child and how they cope best and what works best for them, you know, their favorite color, their what helps keep them calm. When they get IVs, what are some strategies that you guys help to use? What works best for them? And if you're not in Chicago and you're outside of at a different state, I would really encourage you to seek out if there is child life services at that hospital and see what they can do prior to your visit, if it's planned, and if it's unplanned, making sure that that point of contact is made. So yeah.
And Heather put in the chat that she's in an area of the country that she's a little bit stuck in terms of maybe Children's Hospital, or, you know, a little bit, maybe not quite so many hospitals to choose from. I hear you. So some of this conversation, I'm taking mental note and trying to figure out how the Margaret Hackett Family Program can reach out to maybe the smaller hospitals, or the hospitals that are further away from. I'm spoiled because I belong in a academic center, and not every hospital is obviously a big giant academic center in Chicago. I get that. I hear you. I was just thinking, boy, that All About Me, a little card, wouldn't that be great if that came out through Hydrocephalus and we just could hand it to every, with all due respect, Dr. Frim, we could hand it to every surgeon and say, this is how we want our care delivered. Sorry, that may be a bit much to take them all on, Dr. Frim, but I'm not afraid.
The surgeons are so soft and cuddly now, you know.
But, you know, Judy, it is something that we actually we're about to put on our website. It is something that we do, that the Hydrocephalus Association has created for those individuals who are transitioning, to give to their adult surgeons. Exactly what Lainey was talking about. Why not? But why not? This is something that we could partner on. Margaret Hackett and HA, we could partner on a kid one, you know, a pediatric version, to keep this one. The other thing that I think is important, and if we can just talk about it quickly, because I want to get into some of the medical questions that are coming in too. I think it's really important. The thing that I've learned in 21 years of navigating hydrocephalus care is to know who's on the medical team and who to go to and who actually has time to speak to you. And so you guys are all seeing these two incredible humans, Lainey and Judy, who are complementing the neurosurgical team at the hospital. Sometimes you don't get to speak to the neurosurgeon. And I know that when you feel like your child is in shunt failure, there's this urgency to like get through to a neurosurgeon and talk to them about what's going on. But sometimes the best internal advocate on a team is going to be the PA, the physician's assistant, or the nurse practitioner who's working the most closely with the group. And so Judy and Dr. Frim and Lainey, please jump in. Can you just speak quickly about you know, who the different players are in a medical team, and where you feel like they are the most useful for a family when they can, you know, when they can and should reach out or ask for one of these people? Because I have definitely called and just bypassed the neurosurgeon and said, is, you know, Lacey available, who was the PA? Because I knew that Lacey would talk to me for like more than 3 seconds.
Who wants to go first? No. Me.
Yeah, go ahead.
I'd love to say I would be the easiest one to find, but that's probably not true. But there are so many ways that this is done in different places. Our institution is a very nurse-run institution, or should I say, nurse and PA-run institution now, and in a sense, that's probably the easiest way to figure out what's going on with your child, presuming that the nurse is on the ball and is watching all the various things that are going on. It is true that the doctors are not around, because our job is to, as surgeons, to take care of people in the operating room, where I'm sure we're all very good at it, but we can't be with the patients on the floor because that's not what we do. I think that the other people that I would call so additional players like Lainey, she has a very interesting role too. That I would. It seems to me to be even better and better each time I see somebody like that, who also will know what's going on with the child. The best. So my answer is that everybody should know something, and somebody should know everything, and that might be the best way to handle the situation. But nursing is morphing, I think, as it always has, and I'm sure that there'll be all sorts of different ways that the children are going to be cohorted and the children are going to be cared for. So those changes are probably going to be for the best as time goes by, especially with the technology around to also watch the patients. What's your way, Judy?
So the caretaker, team, it depends whether you're inpatient and hospitalized or you're outpatient, right? And you're at home and you're concerned and it's the middle of the night and who do I need to talk to, right? So if you're inpatient in an academic center, there is, the surgeon, there may be nurse practitioners and physician assistants who work. Usually they cover neurosurgery specifically. I might know a lot about a lot of neurosurgery and know some about hydrocephalus. You may be, far more educated in hydrocephalus if you're with somebody who's, still learning kind of as we go. There's residents who are in training. It's a 7-year residency program by us. And I think that's across the country. It's fair to ask someone, what year are you in your training? I just want to know, if my child is 15 and it's July and you just started as a resident, last week. As a parent, you might have a little bit more experience than that resident. So you could always ask for the next most senior resident that's available. Now, if you're, and then if you're inpatient, there's the nurse assigned to your child, right? And then there's always a charge nurse and there's always an administrator. So if you're concerned, that would be the chain of command. The charge nurse is going to make the assignments for the day. But the administrator or the manager, there's going to be a nursing manager, and then there's always an administrator on call. And that would be the supervisor truly over that nursing staff for that day. Now, in an outpatient setting, everybody does it a little bit differently. I'm lucky that my job keeps me responsible for the patients several days a week, but usually during the day. I'm not there at night. We have residents that take call for us. Our system is also set up that as a nurse practitioner, I might take direct calls from parents, but most of the parents go through a call center. So if you call in, it goes to the call center sends the message to me, and then I would have to call you back. And I know that's not always a great system. Sometimes you just want to call and actually talk to a real person and not wait for a call back. It's not always feasible to just do it that way, because again, I'm running around doing different things, not sitting in front of a phone. But there are often nurses working within the Department of Neurosurgery. That nurse might be assigned to that surgeon, or that nurse might be covering all of the pediatric patients. Again, a lot of those nurses work mostly the daylight hours. There's always a call system at night. And if you feel like you're calling in and you're just not sure, should I come? Do I need something more? Do I need a medication? And you're not happy with the answer that you got, again, there's always an administrator on call that you could talk to on the phone. Or what I tell my parents is, if you're nervous enough to call and you really think something's wrong, just come in. Just if it crossed your mind that my kid doesn't look quite right, and I think this may or may not be a shunt malfunction, particularly a shunt malfunction. They kind of look like they're having a shunt malfunction. I'm just not really sure. they're vomiting or they're irritable or they saying that they have a headache. They're just not quite themselves, but they don't really look all that ill. If it crossed your mind to call, really think twice. Maybe I should just go in. You might just feel better. And I would feel better because then I can actually physically see the patient. As much as I trust my moms and dads and, you know, grandmas and grandpas, and they tell me, well, this is what they kind of look like. I feel better if I can actually see them and we can talk about it together. For the people that, you know, maybe don't have that experience and are at, you know, facilities that maybe don't have readily available support like that, I'm open to better suggestions, but that's the care team to answer calls as my understanding to most facilities. So.
Great. Kelly, you're going to jump in right before I start moving to shunt malfunction. So welcome.
Hello. So
Hi.
just on that topic, my son is now a teenager and we're still dealing with, you know, other things related to his hydrocephalus. But I think that's a very good point about just going in. I live about an hour and 45 minutes away from our hospital. And so that was always the do I make that trip? Do I not? Is this a flu or is his shunt malfunctioning? And I think as a parent, it's hard to, you know, when they're young and they can't communicate what's wrong, making that decision. But 9 times out of 10, my gut was right. And there was something going on, you know, and the doctor can't tell you over the phone with your description. You go down and they validate your concern.
Yeah, I hear you. And it's a funny thing. And I try to teach my residents. They'll say, oh, this kid came in and he looked like this and he looked like that. But we didn't think it was a shunt malfunction. I'm like, well, what did the mom say? And then they look at me like, what do you mean? What did the mom say? I'm like, what did the mom say? If the mom has experienced a shunt malfunction, even in a non-verbal, maybe a toddler not even walking, or, you know, the instinct of something just isn't quite right looks the same again, you know. So then I try to teach my residents, if parents and families and children have been through a shunt malfunction, it often looks similar. And if the parent says this looks a lot like what I saw before, that's a really important thing to ask and to recognize when it gets said to my residents. I know they think I'm a little crazy, but that's okay. I'm okay with that.
A little crazy, huh?
It's a great segue. Thanks, Kelly, for Judie and Dr. Frim into a number of questions about recognizing shunt failure. And I think it's great we have one new mom on the call. And so she's asking, how would she know if her child's shunt stops working? They've only been shunted for a month. But in that same vein, we also have, how can you tell if your shunt is clogged? So one is, how can you tell if it stops working? How can you tell if it's clogged? And if it's a programmable valve, how do you recognize a shunt malfunction? I know the answer to this, but I'm going to ask you in a programmable valve versus a fixed valve, or even an ETV. So let's talk about signs and symptoms that there might be something going on.
Is this one of the tests where you check off boxes along the way?
Yeah.
Or then we leave blank the other ones? So I can tell you that the end, whoever the person is, the mom, I can tell you if we start at the end of the story, then by the time, well, I would say, you know, before you know it, but very quickly, if your child has a shunt malfunction, then it's really not going to take more than one shunt malfunction to get a pretty good idea of what a shunt malfunction looks like in your child. There's probably as many different ways to see a broken shunt as there are children. And so that's good and it's bad. It's bad because it means the shunts break, it's good because you're watching the same person and it's your person. And so after a malfunction, or hopefully not even more than a malfunction, then you should really know what's going on, or at least you would be suspicious of that. So that's sort of the answer to the end of the question. As far as what the question is, as far as hydrocephalus is, it's really a disease of too much fluid in too small a space. So then you say, what do we do? So the answer is, well, we take out the fluid, but you can't take out the fluid and let it drip on the ground. That's not very nice. You need to find a way of making the fluid go someplace else where it stays in the body. The pressure inside the head gets big when the fluid doesn't have any place to go. And then the child generally will manifest some sort of pain. Not everybody does that, but almost everybody does that. But then again, I would say in parentheses, after one shunt malfunction, then the next shunt malfunction probably going to be very similar. So something to keep in mind. The answer, in a sense, so this is what's in between the first shunt malfunction and then being a terrific shunt mom and knowing all the time whether there's something wrong or something not. But I think the answer is that your child is probably going to behave mostly the same way, and in general, the shunt malfunctions, unless there's been some change in the valve or some other thing that's happened, you will probably know that there's a problem, or even better, you will probably know that there might be a problem. And once that happens, then you have to go see the doctor in the hospital, because every one of those times is a danger. And it's probably better to go to the hospital, have a little workup and find out that everything's fine than to not do so. What I say to the new moms, the new shunt moms, is that they're going to be really great at this. But if they're not really great at this at the first time your child has a malfunction, then you're going to be really great at it for the second time. And that may be all that's necessary, because it's your child, and your child is probably going to respond the same way each time. And so you need to be, so adding parenthetically, it means you need to be calm. You need to have a telephone. You probably need to have somebody else to hang around with your child while you're calling on the telephone. All those things probably going to be necessary, but they're not really that difficult to get to, right? Everyone mostly has a phone, and everybody mostly knows a little bit about their child. So I would say that that's probably the sort of, that's sort of the neurosurgeon looking down kind of thing. Judie probably has like 2 things to say, and then everything will be totally, easy to do.
Yeah, no, I mean, I agree with what you're saying, that true that a shunt malfunction, once you've been through it, so many children look similar or the same through each shunt malfunction, but that the knowing, is this a shunt malfunction, if you've never experienced before, can be, I'm sure, very scary and very overwhelming, and not quite sure what to do. So I tell our new parents that if it looks like the flu, but there's no fever, it could very well be the shunt, right? Unless the the child has recently been operated on in the last 2 weeks or a month or even 2 months, the likelihood that they have a fever from their shunt goes down further out from surgery. You know, so if they haven't been operated on recently and they have a fever and vomiting and they just look terrible, it probably is not the shunt. But if they are irritable and they're vomiting and they just don't look quite right, maybe their eyes are a little not focusing or a little glassy, or it could always be the shunt. And so then, you know, call or come, and so that we can sort through it, especially that first time. I tell my parents, if you come every single month for the first year of their life because you're nervous and you're concerned, and it might be the shunt, we'll keep working through it. And then one of these times it very well might be the shunt, and then we'll have more information because we'll know what your child looks like while they're having a shunt malfunction.
Judy, I think one of the challenges that I'm seeing in the chat is that there are a number of people on the call who live anywhere from an hour and a half to 3 hours from their hospitals. What recommendations, you know, Judy and Dr. Frim, do you have for those individuals? I mean, I used to live a good distance from our hospital, and so I know what I used to do, and I'm happy to weigh in after you both answer. I can weigh it in now, but it is challenging when you do live far away.
Move to Chicago.
Everybody move to Chicago.
I knew he was going to say that. I hear
It's
you.
cold
It is
in Chicago.
That is a hard problem. And definitely we have patients that come, you know, hours when myself and I have another partner with a lot of experience, Amanda Johnson, and when we're around and the parents call and say, you know, it's a 3-hour trip and this is what I'm seeing. Should we come or should we not come? If it sounds like it's a shunt malfunction, you know, we do tell them, try to go to someplace local, call your pediatrician, seek out another provider who can just lay eyes on this child. You know, we have definitely had kids go into their local provider, local pediatrician, and the pediatrician calls and says, this kid just doesn't look good. Then you need to come. But at least there was another set of eyes with your eyes to say, yes, we agree. This child doesn't look good. I hesitate to say that though, because, you know, there are times that a kid doesn't look so great and he's having an acute shunt malfunction, and going to the local provider delays care from being with the surgeon. So in those circumstances, for patients that I know that live far, far, far away, I would say if the first sign that you think there's a problem, either get on the phone, call that local provider, or just, you know, call your local ER, whatever's the closest, and just say, I really think we're having a problem, because I don't want anybody to delay care if it's an acute shunt malfunction. That would be, I wouldn't want that to happen to anybody.
I know when I lived far away from the hospital when my daughter was younger, I would jump on the phone with the PA, and he would also sometimes talk to my daughter because he knew her so well. And so, you know, that was really wonderful. My whole life changed when she got old enough to actually be able to say, I need to go to the neurosurgeon. And I mean, it's like a whole new world, parents, when you do enter that time of your child's life, when they're really participating in their care, when they know that something's not right and they can start to express that. Dr. Frim and Judy, do you ever use like, I'm going to call it telemedicine, but do you ever jump on a Zoom with a family who might be far away and say, let's see what's going on, kiddo?
Sometimes we do. We have a lot of people that live far away, if you want to call it that. And not that there's not a hospital between where they live and Chicago, but a lot of it, at that point, a lot of it, it's the communication with the family. And so we need to see what's going on, so to speak, but we can't see it because we're not there. So, but you're the mom, right? So you know everything. And probably if you have a hunch that something is not quite right, then probably if I picked up the phone sitting in the locker room at the hospital, I would say, well, what do you think? Is this just like what happened the last time the shunt broke? And then you'd have to answer. Or if it was your daughter, you could ask her, it sounds like, and she had the answer. But that's at the end of the problem, because it's not really a problem for you anymore, because she's going to say, oh, we got to go. I got to get my shunt fixed. So let's just grab some underwear and let's go. But I think that the real problems come up with the families who have a child. The child has hydrocephalus, the child gets a shunt, and is good for 2 or 3 or 4 years. And then they start looking like they have a shunt malfunction, but the shunt has been working for so long. And then I would say, well, that's really great. The shunt worked for a long time. But if it's like any of those symptoms, then it may be the first shunt malfunction. So then you're going back to, in a sense, what's it like to have a shunt malfunction? And then that algorithm comes up, which is, okay, you're a shunt mom, but you have a shunt child that's not ever had a shunt problem. Now you got to go to the hospital, and you got to do it fast, because we don't know whether your pressure, if your child's pressure is going to go up fast or slow or stop in the middle or anything. So that time in the middle where nobody really knows the answer is very important. It's important when it's 3 months after the shunt goes in, and it's probably even more important 3 years after the shunt goes in. And all those, if you look in the back of the book, or at least one of the books, there's like some pictures that give some descriptions of various things that could be going on with the shunt malfunction. So yeah, it's a barring moving into a city that has a big hospital, then you have to sort of think, so where are we going to go first? We're going to go to the hospital that's 12 miles away. Why are we going to do that? Because you don't really know what's going on. Okay, so they go, you go, your son or daughter hasn't had a shunt malfunction ever. So in a sense, you're starting from scratch, but because you've been worried about this for 5 years.
I'm so glad you
And,
did acknowledge that it can change. It really can change at different stages of a child's development.
But the best part is that children usually grow up.
Mhm.
And that's really good, because then they start talking. Sometimes they talk a lot, but that's even better because you're getting more and more information. But that's very important. It's so easy on the patients who have 3 or 4 malfunctions to treat them, and treat them expeditiously, because the symptoms are usually recurrent. And so I'm sure that your daughter is really great at telling you that there's a problem. Why shouldn't she be? Because she's had that happen. And so, as scary as it probably was the first time, as you said before, she kind of knew what the drill was going to be. So, and so keeping calm is really, 50% of the whole thing.
Yeah, and I hope that out of the pandemic that we do have more, as we come out of the pandemic, that we have more telehealth. How can I get an expert on the phone? I have a long ways to go. How do I get answers to my questions? I think this might be a shunt malfunction, but I'm not sure. I really hope that we continue to creatively find resources and support for those kinds of situations. In the chat, somebody asked a question, how much time do you have to get to the hospital before there's any damage from a shunt malfunction? Well, it depends. It depends on the hydrocephalus that your child has, what kind of shunt you have, how long it's been malfunctioning. All the shunt really does is, divert the cerebral spinal fluid, like Dr. Frim had said a little while ago. But, how long has it not been diverting adequately to meet your child's brain needs, right? You make the fluid has to go someplace else in a perfect balance. When it's not perfectly balanced, that's a shunt malfunction. So how long has it not been balanced? How long has the brain been under pressure, not balanced? What exactly is the shunt malfunction? Is the proximal catheter completely clogged? It's not draining at all? Or is there a break in the distal tubing that maybe there's still a little bit of fluid getting through? So it really depends. But I would say that it really depends on the symptoms. It'd be great if every baby had a ticker tape across their forehead that says, I'm developing pressure, and in an hour from now, I'm going to be irritable. And in 4 hours from now, I'm going to be really irritable and I'm going to be vomiting. And in 8 hours, I'm going to have an acute shunt malfunction and everybody's going to scramble like crazy to help me. It'd be great if they just had ticker tapes and we could all read it and we'd all know what's coming next. It doesn't work that way. So I would say, how much time before there's damage? Well, if you really think it's a shunt malfunction, then time is of the essence to get treatment, as soon as you can, so that we can, mitigate and limit the amount of damage that occurs. That's not a good answer, and I know that's probably not comforting, but that really is the answer, because everybody's a little bit different. I have some kids, yes, they have low headaches and clearly they're having an acute shunt malfunction, but that's their symptom. And other kids, they have a terrible headache and they're vomiting and they become very, very sick very quickly. Everybody's a little bit different, but like Dr. Frim said earlier, your child is your only patient, if you will, even though it's your child. You know the symptoms best. You know your child best. And it'd be great if everybody could, find a provider that hears what you're saying and be able to act in a timely manner.
I feel like Denise has had her hand up so patiently. I know it's hard to hold that up for that long, Denise. But please ask your question.
Hi, it's Denise and Nestor. We're here together. I'm her husband.
Hello.
Hi, guys. But,
I feel like I'm on a I feel like I'm on a radio show.
Yeah, but our question is just like, how long? We know that there's a lot of shunt failures and stuff like that can happen, and we had an episode of overdraining with our son. But how far between having it replaced already do we need to start considering that maybe it's something else and not the shunt? I mean, is there a point? Is there a point we gotta come to ourselves and say, hey, let's look at everything else that's causing the vomiting and the headaches? Like the migraines, or is it just keep going back until we can maybe pick the right shunt? I don't know. I'm just lost in that. I don't know if I got the question across right.
So is the question? So I'm trying to ask you the question so that then I can take a guess. So your child has a shunt. Is that correct?
Correct. And he did have overdraining issues, but some months back, and we did switch it out for Orbi Sigma, but he still has all the same symptoms from before the replacement. Still the migraine episodes with the vomiting, the 2-3 long days of not being able to get out or anything at all, and we're kind of told that it takes time, but for it to adjust. But how much time should we actually give ourselves before we start seeking other treatments, or should we really look at Huh? Yeah, should we really look at migraines or really have that new valve checked again? You know, it's just kind of hard to.
So in, I guess, for being in generalities with this, what was there if there were shunt malfunctions before this happened, then it would be, you could say it would be unusual that would be a shunt malfunction. However, there are some children that when they grow, their symptoms can change somewhat, sometimes a little bit and sometimes more than that. Though in general, hydrocephalus is a disease of too much pressure from too much fluid in too small a box. So if there's still all those symptoms and they've changed the shunt out somehow, some way, and there's still symptoms, then there's probably something else that's causing it. How to get to that is a whole different story, because I don't really know much about your child, though it seems that if a reasonable neurosurgeon is changing out pieces of the hardware or any other of the pieces of the shunt, and the symptoms are the same, then it may be that there's something else going on. So I would, this is sort of the A+ of shunt management, because there are times when the children change, their symptoms begin to change. The child grows very tall, and then all of a sudden the tubing is not long enough, but nobody really notices it because it looks like it's long enough. And there's all these things that you can think of where you've done a revision and it seems to be all better, but it's not all better. But it's true, it's no fun, of course, if somebody is getting shunt revisions all the time and still has the same symptoms all the time.
Thank you.
Difficult. It's a difficult problem.
Yeah, it hasn't been, but thank you.
Yeah.
Are there other questions? We talked about shunt malfunctions quite a bit. I think part of the question originally asked, how do you know if the valve is clogged or the valve is working, or something about the magnetic valves? I don't remember who asked that question, but in terms of an acute shunt malfunction, there's no way to know specifically that the valve is working, not working, or clogged, just that the whole thing is not meeting your needs. But we have found for some patients, and I don't know what kind of valves everybody has, or that their child has, we have found for some patients that the advent of the magnetic adjustable programmable valve was really, really nice, that as the kids continue to grow, maybe when they were really, really small, one setting really served their needs quite well. And as they grow, that setting maybe doesn't serve their needs quite as nice as it had when they were smaller, because now they're taller and they're bigger and they have, more space to drain their CSF fluid from the top of their head into the distal catheter. So I don't know if everybody's using programmable valves or not, but that is one thing that we do, consider if somebody's having a lesser, we'll just say a lesser, less acute, not so critically ill shunt malfunction, meaning that the shunt isn't quite serving the drainage needs for how the child has grown and adapted. I don't know if that makes sense, but I throw that out there for a topic of conversation.
Yeah, well, the children grow, and it is true that oftentimes their standard way of manifesting shunt malfunction changes a little bit, particularly during pubertal growth spurts. So that's something to watch.
We had a question that I don't want to skip because it was asked. Hold on one second. I just have to roll up on the chat to find it. Okay. Well, Steve, I think we did just answer your question. Judy did just answer your question for the most part about when to change a valve and why a valve might be need to be changed, especially as a child is growing. If you have a follow-up, throw it in the chat. Carmen asked a question, and I do a lot of work with the teens and young adults in our community. And this actually an earlier question I think that Denise and Nasir, I think, asked was kind of relates to this, though they have a toddler. The prevalence of migraines as a comorbid condition to hydrocephalus, headaches and migraines. I think for teenagers and young adults and adults with hydrocephalus, a lot of them will often say headaches are a part of my life. And I know that there's some research that's starting to be done. Dr. Iskandar, has been looking a lot at headaches and hydrocephalus. But with some of your older patients, Dr. Frim and Judy, this whole issue of how do you know if a migraine is an indicator of shunt failure, or are there patients who are gonna live with migraine or headache? And how do you help those families with those challenges?
So that's a complicated problem, because there's a variety of questions that you need to ask. First, I would say, did the child have headaches when they were 2 or 2.5 years old, or 2.5 or 3 years old? And does migraine run in your family? Because migraines run in families. That may be a different, if you want to call it that, different disease from the hydrocephalus. So so that's one possibility. That's an example that it may be something different. If it's very bad, then there have been times where we've done a lumbar puncture with some sedation to see if the pressure is high. That would mean that the shunt's not working. And since headache is part of the hydrocephalus sequence, then it's possible that the headache is a shunt malfunction. And then how old is the child? Is this the time that the child is sort of starting the pubertal changes? And then there's a lot of patients, some are with hydrocephalus that start up their headaches that are related to their shunt at that point. And so it sort of leaves mom holding the bag in some ways, because it's much easier if there's just one way that the shunt malfunctions in your child, and all you have to do is watch for that. But it's not 100%. So I know that's a little bit of a, what should I say? A little bit of a cop-out, but I think that it's not unreasonable. If the headaches are bad, they need to get worked up. So there's a variety of ways to do that. And it may turn out that the migraine is just a migraine, and it all goes away with a migraine medicine. I mean, there's a whole migraine workup that we do sometimes just to see if the hydrocephalus person now also has migraines. becomes very complicated. And the older the children get, then the more complicated it gets. So hopefully everyone's 20-year-old child is not having headaches, and that would make everything much better.
The other thing, different from a pediatric standpoint, not a shunt standpoint, is, it's really hard to know in a toddler, are they having a shunt malfunction headache, or are they having a migraine headache, or are they having a headache because I have teeth coming in, or do they have a headache because I'm dehydrated? A lot of our kids, when they get to school, that advent of the new semester brings on headaches. Maybe that, sixth grade chemistry starts a whole new series of headaches, or, high school trigonometry, whatever it may be.
Who does chemistry in sixth grade?
Well, they do, Dr. Frim, they do chemistry.
I know
so-
everybody's way smarter than my kids, I'm sure.
So from a pediatric standpoint, when parents come to me and they say, I just don't know, I'm not sure this is a shunt headache, but my kid is too small to really give disqualifiers of this headache. It's, you can't ask a 2-year-old, is it a tight headache, or is it a headache when you stand up, or is it a positional headache? They don't have words to tell you things like that. So Dr. Frim likes to think about all the, complicated reasons that kids have headaches. And then I try to think of the really easy ones. Are they dehydrated? Do they just need some plain old water? When's the last time they had a bowel movement? Maybe their abdomen is just a little bit too full and it's not allowing the shunt to drain to a nice low pressure system within their abdomen. Maybe they were running around at recess and just overdid it and brought on a headache. So that I would encourage people to think about the easy stuff first. And migraines are not fun to deal with, but think of easy stuff first. They're kids first. So why would every other kid on the block have a headache? Well, maybe they're all sharing the same common cold and it comes with a headache. Think through those things easy first. And then if it's really not those answers, and then how do we really know the difference between a shunt malfunction and a migraine? It can get kind of complicated. I agree. It is a little bit easier when they can tell you. But with toddlers, it doesn't mean we don't keep asking those same questions. I have a question to the parents. I write a lot of notes for
Judy, can I just jump in one quick little add on that?
Yeah.
So we do a lot of work with Dr. Jack Walker, who is one of the original first pediatric neurosurgeons in the country from that group. And he gave me the most beautiful advice. My daughter was having headaches around 12:30, 1 o'clock every day in school. And she did not have programmable valves. She had 2 fixed valves. And he said, have her at around lunchtime, see if she can go someplace quiet and just put her head down, lay down for 15 minutes, just let her chill out, see if that helps. And sure enough, it helped. Like the whole afternoon, she was headache free. And it was because, we didn't have this ability to, adjust her valve because she didn't have programmable valves. So we didn't have like the nice little incremental adjustment opportunities. It was surgery or nothing. And, she was just overdraining. And so by just allowing her to kind of like build that fluid back up in her head, it's kind of weird, straight mechanics. She was fine to power through the rest of the day and come home. So in some ways, it's still a very simple, it's a simple and complex medical condition all at the same time.
Yeah. And it's so, anxiety provoking. Your kid comes to you and says, I have a headache. Oh, what if it's the shunt? I get it. My question, the laying down, I tell a lot of parents the exact same thing. So I'm glad you brought that up, because I do write a lot of notes that if this kid doesn't feel so great at school, please let them lay down for 15 minutes. Or I write a lot of notes, especially in the spring in Chicago. Sometimes it can get quite warm, but especially the fall, or also in the fall when the kids are involved in, back to school activities, it can be very, very busy. I write a lot of notes of, please allow this child to have a water bottle at their desk. Kids with hydrocephalus are just naturally a little more prone to be symptomatic when they're a little bit dehydrated. We all live a little bit dehydrated, but kids with hydrocephalus and shunts seem to have a little bit more symptoms with being dehydrated. So if your school system will allow you, or your teacher will allow, just have your kid have a water bottle, and every time they're going out to recess, take a good swig from the water bottle. And when they come back in, another good swig. When we're transitioning between classrooms, another good swig. To just keep them hydrated. That may help just overall with headaches. And the laying down, that's a great suggestion.
Yeah. And Judy, we are slated to end at 9:30. Let's ask your one final question. I asked everybody so I'm putting you both on the spot, Dr. Frim and Judy. I asked everybody if they want to keep this going with another session, maybe in a couple of weeks or in a month or whatever we want to do. And they all said yes. So not to put you on the spot or commit you, but we were slated for an hour and a half. So Judy, give you a little bit of extra time. I know you had some stuff you wanted to get in there. So let's take another 10 minutes and then before we wrap everything up. You're muted. You're muted.
You're muted.
Sorry, I switched my screens and I forgot to unmute. One of the things that I did recently, I talked to the Chicago Public School System. Maybe I can share. Can I share my screen real quick?
I think hold on one sec. Yep, go ahead. You should be able to. Down in the bottom, that green share, or the box.
Oh, there we go.
Arrow pointing up. Yep.
So I gave this talk to the Chicago Public School, and it was about several different congenital anomalies, and I included hydrocephalus. And this was one of the closing slides that I had about long-term management and school considerations. So I have on here the kids with hydrocephalus and CSF shunts are vulnerable to dehydration and may need a water bottle. They're at risk for failure of shunt components with a direct impact, such as like a ball when they're playing in gym and they have a ball come flying at them. If it lands right on their shunt, and that parents may choose to have no contact sports for their child. I hope that you're all receiving support in that way from your school systems. I have on here that kids are at risk for constipation and need a balanced diet. Magnetic valves should be encouraged to stay 6 inches away from magnets, electronics, and whiteboards. And then I really felt like it was important for the school system to know that kids with shunts, on the same topic we were just talking about, may have episodic headaches. They may need hospitalization, surgical interventions, but with rapid recognition should have a pretty rapid recovery. I hope that I spoke well of hydrocephalus, but also spoke well for the parents to the school. And I guess my question to this group is there anything else I should have added to this slide? Did I miss something big from a parent perspective that the school needs to know?
Real hand raised.
How do I stop here? There we go.
I think the biggest learning for myself is reaching out at the beginning of the school year and meeting with the teachers to just talk about your student, because you can hand over the general information, but I have found it much easier for him to get a good start in the school year when the teachers know what to expect and you verbally have that dialogue to allow them to ask any questions, to understand, the headaches, the signs, and to listen to your child because they know their limits.
Makes you a good mom.
Yeah, I just want to echo Kelly. At the beginning of every year, I brought the team together. It got a little harder when my daughter got into middle school and high school, because now you're talking about 7 teachers and or para educators that need to be in a room together. The school was wonderful. They did it with me. I did a presentation about, and I'm talking like a 3-minute presentation, 5-minute presentation about what hydrocephalus is. I talked about it, in ways that were accessible to them. at the end of high school, traumatic brain injury was a term that was being thrown around the media and stuff all the time. So I talked about, brain injury. I used those words to help make it more accessible to them as I was explaining it. And then I did talk about how it impacted her academically. From that, we've created these, and I'm putting it in the chat now. There are downloadable 2-pagers that you can give your child's teacher. The front and back are just a really high level. This is what hydrocephalus is. This is how it impacts learning. And this is how, and these are things strategies that you can use in general to help children. We developed these with Dr. Andrew Zabel from the Kennedy Krieger Institute. And then the second page, which is actually the third page if you're looking at it front back, you're not looking front back, is a fillable PDF where you can type in how your child learns and what helps them in the classroom, or what their shunt failure might look like, or what it might look like if they're having challenges. So you can personalize it for them. So you can hand a teacher a 2-page document. We had a book, and the articles from the book are almost done, and we're about to put them back up on the website. We were just rewriting them. But we had a book, and the teachers were all like, no, I'm not reading this book. So we worked with a group of teachers to develop these 2-page guides. So we hope you find them helpful. Definitely, use them and take that time to fill out. If you need a second piece of paper, put the second piece of paper, attach it to the one that you're filling in. And thanks, Jared. Yeah, the Teacher's Guide to Hydrocephalus, which is the book that I have it sitting here. It is a phenomenal resource. All of those sections are going up on the website, Jared. So, and those will all be downloadable, printable articles, more detail, more for really parents to also become educated about how to talk about some of the learning, health, and social challenges kids face. So when you're in your IEP and 504 meetings, if you need to you have an IEP or 504, you can actually talk about it from an educated standpoint, and you can also show that there are resources about some of the standard challenges that we see in the classrooms. So I hope that those are helpful for all of you, and that you get a chance to use them.
I'm going to do a real life hand raise too. Oh, actually, can you guys hear me?
Mm-hmm.
Okay. I was sorry. My daughter's not in school yet, but I mean, for me, the biggest thing I would want like the teachers and the nurses to know is like, it's okay to tell me if you think something might be shunt related. Like a lot of the times I feel like teachers sometimes see your child maybe more than you do sometimes, especially if you're very busy in like activities and things like that. And it would just be really nice to know that I have someone there keeping track and like noticing, oh, well, this person's acting a little different than normal. Maybe I should mention to their parents this, so that way it's not just like they're not being, so that way they can be, I don't know how to explain it, more on the ball versus having to be reactive to the problem.
Vigilance.
Yes.
That's sort of what you might want to mention to them if they're worried about it. Oh.
Yeah, I wanted, and I'll just echo that, Heather, you're right. And I just put it in the chat. It was actually my daughter's teachers that recognized absence seizures that my daughter was having that looked just like staring off spells, but they were so in tune to her because they were with her 8 hours a day. We weren't really seeing them in the evenings. They were the ones who caught that. And that was, really, really important because it allowed us to then get a neuro workup and get the, the interventions that we needed to support her with the seizure condition. So yes. Well, we are at 9:40 on the East Coast, 8:40 for all of you in the middle of the country. And I know some people joined us from California as well. We have people, Dr. Frim and Judie, we have people from all over the country because I am seeing people that I know who are in all different states across the country. There are so many more questions that I think people would love to deep dive with you both. And so I would love to work with the two of you in the Margaret Hackett Family Program to do another meeting in the near future, if you are both willing to do that.
I think we're stuck with it, huh?
No,
Fortunately, it's a topic we like to talk about, Dr. Frim. So, you know.
Yes. But thank you all for joining. If you think of questions, because I will work with Julie and the team at MHFP to schedule another session together. If you have questions, you can email them to us at info@hydrosoc.org or to write to Julie and everyone at the Margaret Hackett Foundation. Julie, I don't know if you want to throw the email one more time into the chat. We'll gather everything so that we can actually just jump right into some of the questions that everybody has. Lainey, thank you for joining us. I feel like child life specialists don't get recognized the way that they should. We still have a ninja doll that one of the child life specialists had us decorate before one of our surgeries that really helped my daughter. So thank you for all that you do to support families.
Thank you so much. I really appreciate it. And if you guys ever have any questions about helping your children and your children with hydrocephalus and their siblings as well about coping with the medical stressors of the hospital and with hydrocephalus, please feel free to reach out.
So great. So definitely email us those questions. We'll compile them all and we will hopefully see you all soon in the next couple of months for a follow-up. And don't forget, conferences around the corner. We do have scholarships if you do need that. And so please don't be shy about applying for our scholarships. We have incredible donors who want to make sure that everybody can get to conference. So definitely take a look at hydrocephalusconference.org for more information about conference. And you know, the Hydrocephalus Association is here for you all every single day. You can give us a call, you can shoot us an email, you can get us on social media. We are here to answer your questions. We have community network leaders all over the country, a couple of them on this call. They are trained support volunteers. They're also here for you. And then of course, you have the Margaret Hackett Foundation, so family. I keep messing it up. Judy, say it for me, please.
The Margaret Hackett Family Program.
The Margaret Hackett Family Program. There was a C in the email address I saw from Julie. So I'm like, am I missing a word? Okay, so and you also have the Margaret Hackett, you also have the incredible group team at the Margaret Hackett Family Program to help you, and the chat has the email and the phone number. So thank you guys. Thank you, Dr. Frim and Judy. Thank you so much for joining us.
Yeah.
Thank you for having us. This was great.
It really was wonderful. Thanks, everyone. I hope you have a wonderful evening.
Bye, Amanda.
Good night,
Bye,
everyone.
everybody.
Thank you, everyone.